afternoon everyone. Today my topic is on Hydrops Fetalis. Here is a 29-year-old female who came to IFM in view of high risk NIPT for amniocentesis, and her prior obstetric history is like she is now G2, and her first pregnancy she underwent MTP at 24 weeks because of high risk NIPT. And in second pregnancy also she came to be high risk for NIPT, and her blood group is O positive. At 12 weeks of gestation, outside she underwent USG which revealed normal NT, and nasal bone is also seen. And at 15 weeks, ultrasound done at IFM revealed diffuse subcutaneous edema, revealed like her NT is increased. It is around 7 mm, and there is diffuse subcutaneous edema involving all over the body, more predominantly in retronuchal region, and these are the dilated jugular lymphatic sacs on both sides and increased NT. In view of these findings and her blood group being O positive, she is diagnosed to have non-immune hydrops, and there are also traces of bilateral pleural effusion also. So Hydrops Fetalis is accumulation of fluid in at least two of the fetal compartments, like in pericardial space, pleural space, or subcutaneous space, or any ascites. And polyhydramnios and placentomegaly, they are not diagnostic for Hydrops Fetalis, and they can be associated with hydrops. And accumulation of fluid within the body parts, like within the organs, is not considered as hydrops. These are some of the causes of Hydrops Fetalis. They are broadly divided into immune and non-immune causes. And immune causes are like RH isoimmunization. And non-immune causes predominantly they are the chromosomal abnormalities and monogenic disorders. Chromosomal abnormalities, they are predominantly seen in the first trimester. Most 70% are seen in first trimester, and inborn errors of metabolism, they are in the third trimester, most common in third trimester. And second most common cause is cardiovascular causes in second and third trimesters, along with infections. And extracardiac anomalies or like thoracic masses like CPAM, they will cause increased intrathoracic pressure and they impair venous return. And urogenital causes and lymphatic dysplasias, and normal is NT is up to 2.5 mm. When it is more than 95th percentile for a given CRL, it is considered as increased NT, and the rate of aneuploidy is directly proportional to the value of NT. Like if it is less than 2 mm, the risk of aneuploidy is less than 1%. If it is more than NT is more than 5 mm, the risk of aneuploidy will be more than 50%, and if it is more than 8.5 mm, it is around more than risk of aneuploidy is more than 75%. So in cases of Down syndrome, like trisomy 21, the NT is around less than 4.5 mm, and in cases like Turner syndrome, where there is lymphatic dysplasia, it is around more than 8.5 mm. Next, if we detect fetal hydrops on ultrasound, then we have to do the detailed ultrasound, MCA Doppler and fetal echocardiogram, as cardiovascular anomalies are the second most common cause of non-immune hydrops. Then if we detect like supraventricular tachycardia or atrial flutter, then we have to treat the mother with digoxin or sotalol. And if we find any TTTS, then we have to consider laser ablation. And if we find any masses like solid intrathoracic masses or sacrococcygeal teratomas or any other causes which causes increased intrathoracic pressure and impair the venous return, then we have to treat them accordingly. They should be referred for surgery. And if the MCA Doppler in MCA Doppler can be normal or abnormal. If it is abnormal, it is more than 1.5 moms, it means there is fetal anemia is present. So then we have to do maternal, we have to like rule out maternal history of parvovirus exposure or maternal KB strain for any feto-maternal hemorrhage, and maternal antibody profile. And if anything is positive, then we have to treat the patient like fetal anemia. We have to give intrauterine transfusion. If MCA Doppler is normal, then the one more cause is like syphilis, so we have to do maternal RPR. If it is positive, we have to treat the patient like with penicillin. If the syphilis screening is negative, then we have to ask any prior history of offspring having the same history or any consanguinity. Then we have to, if it is positive, then we have to rule out the autosomal recessive conditions like inborn errors of metabolism. Then if it is negative, then we have to do amniocentesis, and we have to rule out lysosomal storage disorders or mucopolysaccharidosis, which causes like visceralomegaly, hepatosplenomegaly, and they will cause hydrops, and also torch screening for the mother.
It depends on what kind of, say, if it is only increased nuclear translucency, which is like 3.5, then there is chances that chromosomal abnormality is causing this is more than rasopathies or genetic syndromes. But if it is very high, like 5, 5.5, 6, that kind of nuclear translucency with edema all around, then chances of non-chromosomal or genetic syndromes are very high. So we may not get an answer by just a microarray. We have to combine with whole exome to get an answer on it.
So how do you proceed with genetics at 32 weeks or 30 weeks? We go for amnio or expect to go for a photosynthesis in that case, because...
See, if it is very late, then at 32 weeks or 33 weeks, even if we counsel them and manage to do amniocentesis, by the time results will come, it will be very difficult for us to act on anything. So it is generally recommended that after 32 weeks, you just follow it up postnatally. Just postnatally you follow it up, do as much as you can, but follow it up postnatally, what's going on with it. But if you see the same thing like 24 weeks or 26 weeks, even though that is also late, but that point of time you can do an amniocentesis and you can at least do a baseline test. When I talk about baseline test, you do a basic microarray, at least microarray, and store the DNA. Or if they agree for, then you have to run both the things together. You cannot be sequential. Microarray, report normal, then do whole exome. If you have to run, you have to run both of them in parallel. You have to run. Okay. So these things we have to understand. And another thing is lymphatics and venous drainage. Like you look at the ductus venosus drainage pattern very carefully. Precordial venous system. Because if the ductus venosus is not there, and the ductus venosus is what is regulatory. Exactly.
Perpendicular.
Yes, it's a regulatory shunt. Yeah. Ductus venosus is a regulatory shunt. If that shunt mechanism is not there, the entire umbilical venous blood is draining into the systemic circulation, which is causing increased preload. So in sagittal section, try to have a look at that pattern of the ductus venosus, whether my ductus venosus precordial venous system is there or not. Are you getting me? So all these little bit of things will help you to at least exclude these causes, which we can do on ultrasound itself, which is in our hands entirely, and then do a genetic analysis test and all these things will be done. Okay.
This is one more patient.
So Develina will prepare on this. Yes. Which case?
One more patient. 2-3 days back we have seen umbilical vein directly draining into right. This patient had hydrops.
This patient, see, so exactly what we were just discussing. So this condition also has umbilical vein. Now I will discuss this in detail. I have a presentation on this precordial venous system, so I will present this. And then in that I will again I will include this slide. Okay, we will do that. So basic thing is if the venous load is increasing on the heart, at some point of the time heart will go in decompensation, and then it will be reflected as this in the form of hydrops. So you just remember this case and get a video loop also.
Yes, I have.
Video loop also, that will help us. And there might be other causes like vein of Galen also in the CNS. But these things anyway we are doing an anatomy scan in detail, so we will be able to pick up. We'll be able to pick up. But your thought process should be that. You have to be like something in fetal medicine. What happens? We see something and then we start retrospectively, we start analyzing the things which we have already seen till now. Then we go back. We have seen placenta, but now again I will go back to placenta. From this edge to that edge, all the margins, everything I will hunt. I will want to make sure I have not missed any chorioangioma. Again I will go back to brain, and again I will see, did I miss any small vein of Galen or something? Because nothing is impossible in fetal medicine. On a day where baby is not in a good position, or you are in hurry, or some bad day, anything may be missed. So always retrospectively you have to analyze them.